So next we'll start with the male genital system. So under the male genital system, we'll be discussing about cryptorchidism, testicular tumors, then benign prostatic hyperplasia and prostatic cancer. So let's start with cryptorchidism. So what is cryptorchidism? Here, the testis fails to descend into the scrotal sac. So the normal location of testis will be in the scrotal sac, but here in this condition, it is high above it. So during embryogenesis, this testis had not descended down into the scrotal sac. So most commonly during this descent, testes which had not descended down will be stuck up in the inguinal canal. So the most common site of cryptorchidism will be in the inguinal canal. So microscopically, if you see, there is going to be developmental arrest of the germ cells. So this is the normal image of the testis. Here all of these are the seminiferous tubules. Okay. So in these seminiferous tubules, we see various stages of development of the gametocytes. So here what happens is the germ cells will be arrested. So they don't develop into mature sperms. So only Sertoli cells will be present or primordial germ cells. So at that stage itself, the development will be arrested. So the mature sperm cells will not be seen. Other than that, if you see, this is the basement membrane of the seminiferous tubules. So in all of these seminiferous tubules, if you appreciate, it is having a very thick basement membrane. So thickening of the basement membrane is again another feature of cryptorchidism. Then because of this, seminiferous tubules will gradually undergo atrophy, and then what happens is the stromal cells here in the stroma will be having the Leydig cells. So Leydig cells will appear as if they are prominent. So it is actually not prominent because of the atrophy of the seminiferous tubules. The Leydig cells will appear as if they are prominent. So these three features are the features of cryptorchidism. So what are they? Developmental arrest of germ cells, then thickening of the basement membrane of the seminiferous tubules, then apparent prominence of the Leydig cells. Since the developmental arrest of germ cells is there, so the patient usually presents with infertility. So decreased fertility will be there, and apart from that, there is also going to be increased risk of cancers. So increased risk of cancers, especially germ cell tumors. So whenever they diagnose this, that the scrotal sac is empty, they'll have to do a surgery in the kid within 2 years of age. So to bring down the testis to the normal location. So this surgery is going to be orchiopexy, which has to be done within 2 years of age. So next we'll see about the various testicular tumors. So under testicular tumors, we have three major categories. First one will be the germ cell tumors, then the sex cord stromal tumors, then other tumors in which we'll have metastasis and lymphomas. So under germ cell tumor, you are further subdividing it into seminomatous tumors and non-seminomatous tumors. So under seminomatous tumor, you just have seminoma. So seminoma is actually the counterpart of what we call as a dysgerminoma in a female. So when I'm discussing a female genital system, I'll not be telling about dysgerminoma because it is essentially the same features as seminoma. Just the name is different over there. So under non-seminomatous germ cell tumors of the testis, you are going to have yolk sac tumor, teratomas, embryonal carcinomas and choriocarcinomas. These again can be seen in the female genital system as well. Then the sex cord stromal tumors, you have Sertoli cell tumor and Leydig cell tumor. So clinically, how do the patients present with the testicular tumor? Usually there will be gradual enlargement of the testis, which is going to be painless. Pain will develop only at very late stages. So there is gradual enlargement of the testis. So the common metastasis of testicular tumors are going to be to the para-aortic lymph node first. Okay. So para-aortic lymph nodes are the first lymph nodes to be involved by testicular tumors. Apart from that, they can also have a hematogenous spread to the lung. So these germ cells, some of these germ cell tumors, okay, so not the sex cord stromal tumors, the germ cell tumors I'm speaking about. So the germ cell tumors, some of these tumors can have precursor lesions which are called as ITGCN, which is intratubular germ cell neoplasm. Okay, so intratubular as in inside the seminiferous tubules only the precursor component is present. Like in a breast we see, right, the DCIS, which is a precursor to breast carcinoma. So like that, the cancerous cells are going to be limited by the tubular basement membrane. They'll not invade. Okay, so this ITGCN was previously termed as GCNIS, which was germ cell neoplasia in situ. Okay, so now they had changed the term to ITGCN. So ITGCN can be a precursor lesion to most of the germ cell neoplasms except teratoma and also spermatocytic tumor. Okay, so these exceptions can be important. So ITGCN is not a precursor for teratoma or spermatocytic tumor. So what is this spermatocytic tumor? Previously, this spermatocytic tumor was classified as a subtype of seminoma only. So they were calling it as spermatocytic seminoma. Now it has all been changed and spermatocytic tumor has been considered as a separate entity. Okay. So spermatocytic tumor is entirely different from that of seminoma now, and now the term has changed to spermatocytic tumor. So spermatocytic tumor is going to occur in elderly age group like more than 50 years, and it usually tends to be bilateral, while seminomas are going to be unilateral and usually it occurs at around 30 years of age group. Okay. So now we'll start with the first tumor, seminoma. So seminoma is the most common germ cell tumor of the testis, and here it's usually occurs in 30 years of age group. So the mean age will be 20 to 40 years of age, and then it is very important because seminomas are quite radiosensitive and chemosensitive. So they have a very good prognosis. And the mutations associated with seminoma will be isochrome 12p and CKIT. So when we were reading isochromes in genetics also, I mentioned about this isochrome 12p, remember? So isochrome 12p mutations are seen in seminomas. So on immunohistochemistry, and also using certain biomarkers. So you can test for certain biomarkers in the serum. So these will be elevated specifically in seminoma. So what are they? Usually they are PLAP, LDH. Okay, so you can measure for PLAP and LDH in the serum, and that will be elevated in seminomas. On immunohistochemistry also, you can apply PLAP, LDH, OCT3/4, NANOG, for confirming the origin as seminoma. Other than that, we can also use beta HCG. Some of the seminomas are known to have a component of syncytial trophoblasts. So when they have this syncytial trophoblasts, these syncytial trophoblasts in turn produce beta HCG, and in those tumors, beta HCG levels can also be slightly elevated, and immunohistochemistry chemically also we can prove the beta HCG can come positive in those kind of seminomas. Okay. So the immunohistochemical markers of seminomas are going to be important. So grossly also you can make a diagnosis of seminoma usually because it has a very characteristic appearance. So the characteristically the testis will be enlarged. Then it is going to be fleshy and lobulated. So in this, if you appreciate, it is having these kind of lobules. On the external surface also, it will have some lobulated appearance. So multiple lobules are present. So it is fleshy, lobulated, and most of all, it is going to have a homogeneous appearance. That is, the entire tumor appears the same. Here it is all looking some tan white in color, right? So homogeneous appearance is a classical feature of seminoma. Usually, you don't get hemorrhage or necrosis in seminomas. And microscopic image is also very characteristic for a seminoma. So the seminoma cells are going to be arranged in these kind of nests. So nests of seminomatous cells which are going to be polygonal. So polygonal or polyhedral cells which have a clear cytoplasm. So can you appreciate, it is all having clear cytoplasm. So clear cytoplasm will be present. Along with that, it is going to have a large central nucleus. So the nucleus is large and central. So these are all the nucleus, and it is going to have a prominent nucleoli. So in this image, if you see, this is the nucleoli. So prominent nucleoli will be present. So the clear cytoplasm of this seminoma cells are due to the presence of glycogen. So when glycogen is present, it is going to be PAS positive. Remember? PAS positive, and it is going to be diastase sensitive. Okay. And apart from that, you are going to see there is going to be some fibrous septae separating these nests. And in these fibrous septae, if you see, there are dark cells, right? So these are all lymphocytes. So these are all the classical constellation of seminoma. Usually they are present in nests, and the cells are polyhedral with clear cytoplasm due to the presence of glycogen. The nucleus is going to be central with the prominent nucleoli, and apart from that, the fibrous septae separating this nest are going to contain lymphocytes. So these form the classical features of seminoma. Next, we'll see about yolk sac tumor. So yolk sac tumor is also called as endodermal sinus tumor, and this is the most common germ cell tumor occurring in infants and in children less than 3 years of age. So in general, if they ask what is the most common germ cell tumor, it is going to be seminoma. In children of less than 3 years of age, including infants, then it is going to be yolk sac tumor. So immunohistochemically, it is going to be positive for alpha fetoprotein and alpha 1 antitrypsin. So both A's will be positive. So serum biomarkers will also be elevated. So if you check for serum AFP levels, it is going to be elevated. And the classical feature you see in a yolk sac tumor will be the presence of this Schiller dual bodies. So Schiller dual bodies are seen in yolk sac tumor. These actually contain a central vessel. So surrounding which there is going to be the tumor cells which are arranged around it. Then there will be a clear space surrounding the first layer of tumor cells. Then again there is going to be a second layer of tumor cells. So this classical appearance is a characteristic for a yolk sac tumor, though not present in all the yolk sac tumors, but when you see this Schiller dual bodies, you can definitely call it as a yolk sac tumor. So the Schiller dual bodies is also given another name called as glomeruloid bodies because it resembles the glomerulus of the kidney. So in kidney glomerulus also you have a parietal layer, and then there is going to be the Bowman space surrounding then inside you have the visceral layer, and then you'll have the glomerular tuft of vessels inside. So it resembles exactly like that of the glomerulus. So this is called as glomeruloid bodies. So where else did you hear this name glomeruloid bodies? Yes. So glomeruloid bodies we also saw in glioblastoma. So in glioblastoma, one of the features was microvascular proliferation, right? So when there is lots of microvascular proliferation, it is going to appear just like a glomerular tuft. So there again, it was called as glomeruloid bodies. So moving on to the third type of germ cell tumor, which is embryonal carcinoma. So embryonal carcinoma is a bad type of tumor. Basically, it is composed of undifferentiated cells. So poorly differentiated or undifferentiated primitive cells are going to be present, and there will be lots and lots of hemorrhage and necrosis in this tumor. And it's a very high grade tumor, and immunohistochemically you can prove the presence of embryonal carcinoma with using CD30. So CD30 is going to be positive in embryonal carcinoma. Usually it doesn't come up as a pure tumor, it comes as a mixed germ cell tumor. So multiple germ cell components will be present in the same tumor itself. Usually you'll have a yolk sac, embryonal, and a teratoma or a seminoma kind of a combination. So whenever you see the embryonal carcinoma component in the mixed germ cell tumor, you will have to report the percentage of the embryonal carcinoma, so that as it contains the worst prognosis, the percentage of documenting this embryonal carcinoma is important. Then we'll see about the next germ cell tumor, which is teratoma. Teratoma we are all familiar with. So it is a germ cell tumor which is going to arise from more than or equal to 2 germ cells. So at least 2 germ cell layer, from there the derivatives should be there. So it can happen either as a prepubertal or a postpubertal tumor. So in prepubertal age group, it usually comes as a pure tumor. That is, there will be no mixed germ cell component. It comes as a pure teratoma, and it is going to be usually a mature teratoma. While in a postpubertal male, if there is a testicular teratoma, it is usually malignant. So unless otherwise proved, it is considered as malignant. So teratomas, any of the components of the teratomatous derivatives can turn into malignancy. So the most common component which turns into malignancy is a squamous component. So squamous is an epithelial component, right? So the three germ cell layers will be the epithelial, endodermal, and the mesenchymal. So the squamous epithelial component can turn into malignancy, developing into SCC, and this is quite rare, and it is only occurring up to 1%. So normally a mature teratoma tends to be cystic in appearance, and it is termed as a dermoid cyst. While an immature teratoma is going to contain some solid areas as well, and this immature teratoma, where you call it as immature when you see neuroepithelial. Neuroepithelial components, if it's present in the teratoma, it makes it as a immature teratoma. So grossly also you can identify a teratoma because it is going to have some derivatives of all the 3 germ cell layers. So classically we'll be able to identify hair, bone, teeth, or even keratin flakes, which appears as a putaceous material. So the protuberance on which this bone or teeth is seen is usually called as the Rockitansi protuberance. So here, if you appreciate, you can see the hair, teeth also, and then in between you can see some material which is kind of white to yellow, right? So this is going to be the keratin. Then microscopically, as I mentioned, you can have tissue derivatives from all the 3 germ cell layers. So here in this image, this is the cartilage. So this part is the cartilage. Cartilage is going to be the mesenchymal component. Here if you see, it is forming some glandular component lined by some cuboidal or columnar cells. So glandular is going to be epithelial component. Again here if you see, it is having keratin and some kind of squamous lining also here. So keratin and squamous lining again is going to be an epithelial component. So various kind of derivatives you can see. In this image, it is the epithelial and the cartilaginous component which is seen here. Then we'll see about choriocarcinoma. Choriocarcinoma is going to be quite rare and it usually comes as a part of a mixed germ cell tumor. So here the classical biomarker which is elevated in the serum will be beta HCG. So beta HCG levels will be very high, and on immunohistochemistry also beta HCG will be positive in these tumors. So usually it occurs in young adults like of 20 to 30 years of age, and even though it is a very high grade tumor, it is going to be highly chemosensitive. It is going to respond to methotrexate. So gross image again in this tumor like in this tumor again, like embryonal carcinoma, grossly you can have lots of hemorrhage and necrosis. So entirely the tumor is going to be hemorrhagic and necrosis. Hardly you will be able to see some kind of viable tumor. And on the viable areas on microscopy, if you see, there is going to be sheets of trophoblastic cells. So sheets of both syncytiotrophoblasts and also cytotrophoblasts will be present. But normally these syncytio and cytotrophoblasts are components which form the villus. So villus in the placenta. So villus structure in the placenta is going to be formed by these cyto and syncytiotrophoblasts. But when these form the choriocarcinoma, they do not form any villi. It is just sheets and sheets of these trophoblastic cells along with hemorrhage and necrosis. So the cytotrophoblastic cells are going to be polygonal like this. So the bigger cells are cytotrophoblasts, while multinucleated giant cells which we see here are going to be the syncytiotrophoblasts. Okay. Now we had seen about all the germ cell tumors. Next we'll see about the sex-cord stromal tumors, starting with Leydig cell tumor. So all the sex-cord stromal tumors are usually benign. So most of the times it is going to be benign. Very rarely they go in for a malignant transformation. So the first tumor will be Leydig cell tumor. Here again it is a sex-cord stromal tumor. The very important thing about Leydig cell tumor is a hormone. It is a hormone producing tumor. It produces testosterone, and due to the presence of this testosterone, it is going to produce symptoms early. So it will cause masculinization if it's in a female. Suppose it was an ovarian tumor, so it is going to produce masculinization. If it was a male, it is going to produce precocious puberty in a child and gynecomastia in an adult. So grossly, if you see, it is going to be a well circumscribed homogeneous tumor again, but on cut surface, it is going to appear kind of golden yellow. So this golden yellow cut surface is due to the presence of lipid. So these Leydig cell tumors, they are going to produce steroids, right? So testosterone is a steroid. So steroid, if it needs to be produced, it needs lipid. So these Leydig cell tumors are going to contain lipid. So that is why the cut surface appears golden yellow. So whenever lipid is present, what is the special stain we can use to prove its origin? Oil red O, right? So oil red O can be used only on frozen section though. So if you take a frozen section of this Leydig cell tumor and apply oil red O, it is going to come positive. So what is the testicular tumor which can show oil red O positive? It is going to be Leydig cell tumor. So microscopically, if you see, the Leydig cells are going to appear polygonal with some granular eosinophilic cytoplasm. So all these cells are granular, having a granular eosinophilic cytoplasm, are Leydig cells, and it contains two L's. So first L I already mentioned, it is lipid. So the second L for Leydig cell tumor. So all L's are there in Leydig. So it is going to be lipofuscin. So lipofuscin is a wear and tear pigment. We all know that, right? So lipofuscin is also going to be a component of Leydig cell tumors. And another feature which we see usually on microscopy and on cytology is Rinke's crystalloids. So it is going to inside the cytoplasm of the cells, you are going to see these kind of crystalloids. These are characteristic for Leydig cell tumors and they are called as Rinke's crystalloids. Even in this histological image, if you appreciate, these are all Rinke's crystalloids, pinkish material which are present, no? So these are all the Rinke's crystalloids. Then Sertoli cell tumor is another sex-cord stromal tumor, but here it is going to be hormonally silent. So S for silent. So Sertoli cell tumor is going to be silent. Testicular lymphomas, these are usually the most common lymphomas which we see in elderly age group above 60 years of age, and it tends to be bilateral. And the most common microscopical image of this testicular lymphoma will be, it is a DLBCL morphology. So diffuse large B cell lymphoma morphology will be the classical finding in a testicular lymphoma, and these are quite aggressive and it's known for spread. So by the time they had developed a testicular tumor, it could have metastasized to the CNS also. So microscopically, if you see, these are the seminiferous tubules you see here. So in between this, it is all filled up with these dark blue cells, right? So these are all the lymphoid cells which is composing the lymphoma. Okay.